now move to second session with Dr. Hatem Suleiman. Dr. Hatem will talk about subsequent line for metastasis endometrial cancer. Floor is yours, Dr. Hatem.
Assalamu alaikum warahmatullah.
Assalamu alaikum.
Can you allow me share screen? It's sharing showing or no?
Yes, Dr. Hatem.
Okay. Bismillah ar-Rahman ar-Rahim. Thanks, Mr. Chairman, Dr. Abdulaziz, and thanks for GSK for allowing me to discuss this topic with you this night. I hope I can summarize all of this data in the second line, and thankfully, Dr. Ali made my job easy for taking the first almost 20 slides from me. I will discuss today in the few minutes, inshallah, in evolving treatment paradigm for endometrial cancer in second line, as we saw Dr. Ali already discussed first line. This is again the distribution in the Saudi population about the endometrial cancer, and in age groups also. I want to discuss this slide. It is real world evidence reflects the poor outcome. Unfortunately, for this endometrial cancer, it is one of the lethal cancer in the female population before the era of immunotherapy. This was the median overall survival 10 months, and for time to next therapy 7 months. The 5-year survival stratified by histology, as we used to do in the past. Serous 45%, clear cell 65%, endometrioid 91%. The rationale of biomarker analysis, as we told in the past, we used to differentiate between types of endometrial cancer based on histopathology only. High-grade endometrioid, carcinoma, serous, clear cell, undifferentiated, mixed, and gastrointestinal mucinous type, and carcinosarcoma. But in this era of genetic and molecular analysis, this slide comes, what a horrible slide, but it is simply differentiates endometrial cancer into 4 categories, as Dr. Ali discussed. It's Pol E, it's MSI high, copy number low, and copy number high, with the best prognosis for the Pol E and worst prognosis for TP53 abnormality mutation, copy number high. So, what is the rationale of monotherapy? Monotherapy, as we told before, it was the standard of care in the second line, and it was based mainly on chemotherapy. And this slide summarizes almost all studies for those chemotherapy agents: topotecan, paclitaxel, oxaliplatin, docetaxel, exivapilone, gemcitabine, and etc. etc. And for overall response rate, I want you to remember this number. It's up to 32% overall response rate as a median for all those studies. Progression-free survival up to 4 months, duration of response 10 months, overall survival less than 14 months. But I want you to remember this 32% overall response rate. As Dr. Ali discussed, chemotherapy, carbopaclitaxel, was non-inferior to doxorubicin, and with add-on of trastuzumab for HER2-positive upfront in the first line HER2-positive uterine cancer, it came with a hazard ratio 0.5 and improved overall survival. So this is the point. They decided to personalize more the treatment options in the second line, because the backbone carbopaclitaxel is assigned for the first line, and in the second line we are in a mess, we are lost how to approach this current difficult situation, and how to categorize or step the second line options. In this scenario, immunotherapy emerges as a game changer in the management of endometrial cancer. IO monotherapy mechanism of action. As we know, this is repeated talk about immunotherapy. The MSI means that this tumor carries 10 to 100 times of as many somatic mutations, and somatic mutations we can tell that it stimulates the immune response that can initiate the immune reaction to fight these tumor cells, but unfortunately the tumor cell can escape this immune response. That's why we are introducing PD-1 inhibitor and BDL1 inhibitor to break down this bypass mechanism of tumor cell. We can reach here, and to summarize, to focus, what can we do in the second line? Immunotherapy first, second ADC, third hormonal treatment, and four new approaches. Just to summarize, not to be confused with this large data we will discuss. First of all, immunotherapy we will discuss. ADC is the second, hormonal is the third, and fourth new approaches. This is NCCN guidelines which was adopted upon the new data from our studies, and we will focus here in this line useful in certain circumstances, in proficient MMR, tumor mutational burden high, MSI high, and in the end we will discuss in HER2 positive, and in the end lastly NTRK. In this slide it summarizes a little bit the immunotherapy in the deficient MMR endometrial cancer with effectiveness as a single agent. First of all, we will discuss Garnet trial. Upon it approval of dostarlimab came Garnet study. It is a phase 1 single arm study of Jemperli monotherapy in multiple tumor types. I was wondering why this approval came upon a phase 1 trial, but as we mentioned before, that the results from the second line chemotherapy was disappointing. So with the results from Garnet trial, which it came, I will show you now, as a marvelous that drove the authorities like FDA to have approval for dostarlimab single agent in deficient MMR. This Garnet study passed some steps in part 1 dosing and part 2 fixed dose safety and expansion cohort, and it came in the part A1 concluded and focused in the deficient MMR patients, and collected data in the result upon dostarlimab single agent immunotherapy. This was the dosing as discussed before, 500 every 3 weeks, and for the after the 10th week, it means 4th cycle, you can increase the dose and widen the interval to 6 weeks. I want here also to discuss that the enrollment of patient was 153, and 10 patients were excluded for no measurable disease, and then excluded some patients for progression and adverse events and upon patient request. Lastly, it came 108 number of patients, and this was collected data for progression and adverse effects. Then all number 45 patients remained in the end. For this demographic and baseline characteristic, you can see here that stage 3 and 4 was about 56% and included almost all histopathology types of the uterine endometrial cancer, except carcinosarcoma was 0. And prior lines of therapy, there was patients with only first line, and patients also for post second line, and also patient post third line. It shows also efficacy. This is the overall response rate, which number I wanted you to remember for this chemotherapy. It was 32% overall response rate as a median of all these trials, but in Jimberly here it showed overall response rate as a 45%. That's why, as I told you, it got the approval very rapid when it showed this marvelous compared to others marvelous overall response rate, and the median duration of response not reached. Here also we can see in this waterfall that the CR with the blue lines and the BR with the green lines, as you can see here, the overall response rate. Also, the duration of response, probability of remaining in response at 24 months was 83%. How marvelous was this? 24 months, this means 2 years. 83% probably of the patient will remain in response. The safety and the adverse event, as it is single agent, as we know, this class effect for immunotherapy, grade 1 and grade 2, it happened and it is manageable, and 8% only of patients discontinue treatment due to treatment-related adverse events. As usual, fatigue, diarrhea, nausea, this is the most common. Also, as we told, it is class effect, and hypothyroidism is the most common side effect, manageable side effect. And with this also duration or interval between doses, 500 mg q3 weeks equals almost 1000 mg q6 weeks. Also in side effects, there is no increased side effect with increased dosing. There is almost the same side effect even with increased dose and duration, increase the spacing between doses. So the key points for this Garnet trial that demonstrate durable anti-tumor activity in deficient MMR. Also, deficient MMR by immunohistochemistry was associated with higher response rate. That also I am confirming, Dr. Ali, this information, that immunohistochemistry equals to BCR, and the evaluation was by RECIST and also IR RECIST were consistent and accepted the safety profile even with the higher dose and the increasing spacing. This treatment-related adverse event are equal, and there is no increase in the side effect with increased dosing. So that's why Saudi FDA approved dostarlimab as a second-line post-failure of first-line chemotherapy. This also conclusion for Garnet. Almost it is the largest prospective data about this immunotherapy in endometrial cancer, higher activity in dMMR, and showed durable response in this dMMR, and safety profile also is very accepted, as we told, the class effect. We will raise one question here, that this was approved, unfortunately, before approval of Ruby trial and GY018. So there is a lost question here, or a lost answer here. Can we give after first line immunochemo or no? But let's see the coming data. Immunotherapy, again, these slides we will discuss about pembrolizumab, Keynote 158, and its data. Again, it showed overall response rate 48%, and we want also to be focusing in that Keynote 158 is a phase 2 basket study investigating anti-tumor activity of pembrolizumab in many solid tumors, including endometrial cancer, and the number of patients was 68. That's why when we are telling about Garnet trial, that the number of patients is 108, and finally it concluded, or it came to 45 patients. This is accepted number of patients compared to other trials in this category. We finished dostarlimab. We finished also pembrolizumab. Also in NCCN, they approved avelumab and nivolumab as single agent immunotherapy in deficient MMR endometrial cancer. What about combination between TKI and ICI, immune checkpoint inhibitor? This came from a phase 2 study, Keynote 146. A rapid accelerated approval was initiated 2019 that pembrolizumab in combination with lenvatinib for the treatment of patients with advanced endometrial cancer, proficient or not MSI, means MSS, who have disease progression following systemic therapy in any setting and are not candidate for curative surgery or radiation. You can use, based on this phase 2 trial, phase 3 trial was initiated as Keynote 775, lenvatinib pembrolizumab, randomized trial, lenvatinib pembro versus doxorubicin or paclitaxel, and the primary endpoint was progression-free survival by BICR and overall survival. Also secondary endpoint, overall response rate, quality of life, and safety. Also duration of response was mentioned and focused. In this trial, median progression-free survival was 6.7 months compared to chemotherapy 3.8 months, almost double, and overall survival was 6 months apart, chemotherapy in favor of lenvatinib pembrolizumab. So FDA approved pembrolizumab lenvatinib based on phase 3 Keynote 775 in second line therapy. We reached here the end of immunotherapy discussion, and we will shift to HER2 targeted therapy. HER2 positivity is obviously showed in endometrial cancer. That's why, as we mentioned before, in phase 2 trial, carboplatin paclitaxel versus adding trastuzumab to this backbone chemotherapy showed here overall progression-free survival, and for here also showed overall survival in the first line. What about the second line? Second line was tested in PAN Tumor 02 Destiny trial, phase 2 trial. It was also checking multiple solid tumors based on the HER2 status, and the TDXD effect on those tumors was obviously shown here. Overall response rate you can see here. That's why I'm telling, just remember the overall response rate. It was 32 in chemotherapy, it was 46, 47 in immunotherapy. In TDXD IHC immunohistochemistry plus 3, it reached 84, plus 2 it reached 47, That's why in NCCN they approved TDXD in second line HER2 plus 3 and also plus 2 without fish. Without fish. You are not forced to do fish in plus 2. You can use TDXD directly if the immunohistochemistry is plus 2. In April 2024, FDA granted accelerated approval for TDXD as tumor agnostic for solid tumor in immunohistochemistry HER2 plus 3 and for endometrial also plus 2. In the HER2 low, as in breast, they are now ongoing. There is ongoing trials for approval TDXD for HER2 low. We finished immunotherapy. We finished approved ADCs, and we are reaching here hormonal therapy. We will bypass rapidly because this is low toxic, affordable treatment which showed accepted results for endometrial cancer. Preferred regimen everolimus letrozole, which showed here progression-free survival, median 6 months versus 4 months, okay, and overall survival 31 months versus 16 months. This is the marvelous result, almost doubled, and for this letrozole everolimus, and also the letrozole with abemaciclib CDK4/6 inhibitor, abemaciclib, and also approved for ribociclib as per NCCN guidelines here. Letrozole ribociclib, letrozole abemaciclib. For abemaciclib, it showed median progression-free survival 9.1 months. I want you to remember that this patient is heavily pretreated, and there is no more option to offer this patient to reach progression-free survival 9 months with simple CDK4/6 inhibitor and letrozole with low toxicity in heavily pretreated patients. This was a good achievement. What about the new investigational studies? What about the TP53, anti-HER2? What about DNR damage repair? What about hormonal therapies? There is for TP53 selinexor. You can hear about this drug. This drug is used as a maintenance after CR or partial response in patients who received already 12 weeks or more of taxane carboplatin. You can offer selinexor as a maintenance of response, which was compared to placebo. What is the selinexor effect? Selinexor effect was in TP53 wild type, not mutated type. TP53 wild type. It showed progression-free survival in favor of selinexor. It showed also progression-free survival PFS2 also in favor of selinexor, and also time to subsequent anti-cancer therapy was in favor to selinexor, which all in the end translated into overall survival. This selinexor prevents the kicking out of TP53 wild type, which is tumor suppressor gene, from the nucleus. It collects the TP53 inside the nucleus, making the cell to drive self-killing apoptosis. Also, there is immunotherapy. Lifileucel, it is like sibuleucel in prostate. It gathers the T cell infiltrating lymphocytes. It is also ongoing trial. Bertuzumab plus trastuzumab is also under investigation. in HER2 positive, tucatinib, wait for tucatinib, he is coming for HER2. And the answer about IO after IO. What is this? What can we do if we used before IO and the progression came? This study also discussing and checking what about cabozantinib plus nivolumab after progression on nivolumab. Also, there is one study checking the activity of pembrolizumab and lenvatinib in DMMR, endometrial cancer patient who failed pembrolizumab monotherapy. يعني the patient received pembrolizumab and progressed, failed, then you will add lenvatinib to pembrolizumab and it will check the results. And end of all, for this HER2 also there is trastuzumab deruxtecan with rivogostomig. This is also a PD-1 inhibitor. Trastuzumab deruxtecan with Pembro, carboplatin paclitaxel with Pembro, 3 arms, also under investigation. Sacituzumab juvotecan, it's coming. Dato deruxtecan coming. Sacituzumab triomotecan, it's coming also. This all under investigation. I hope I summarized all this data and focused in the important information to help this poor patient, unfortunately, to overcome this very aggressive malignancy. And thanks for all.
Thanks, Dr. Hatem, for this nice presentation. Now open floor for question.
I think this is
Dr. Ali.
Yes, I think this is large topic. يعني to collect question. Many of questions we can answer, but unfortunately many of question we cannot answer. Yes.
الله يعطيك العافية. دكتور علي.
Yes, Dr. Aziz.
طيب, my question for you, Dr. Ali, الله يعطيك العافية. If you have patient endometrial cancer came with the MSI stable, what's your recommendation for those patients?
Currently we are using those medication which has been approved by Saudi FDA. So the approval for the distal approved for TMMR, yet they did not get the approval for proficient TMMR. So if I talking widely, the immune therapy that FDA approved, we can use pembrolizumab, we can use dostarlimab, we can use durvalumab. However, you have to consider something, the patient status and the duration of treatment that you will use, the histological subtype, and the availability of the drug, and all of these play a role in the choosing the first line in the presence of all of approved medication. And there is no head-to-head comparison between those all immune checkpoint inhibitor. But like I mentioned, for those patients who only finished 6 months and they have recurred after 6 months, I might use the dostarlimab. It is in the inclusion criteria, they allowed for more than 6 months duration.
Yes.
After 1 year, and the other trials in those patients, carcinosarcoma, all of these items, it will detect the decision that I will make in the front of the patient.
Thank you, Dr. Ali. My question for Dr. Hatem. The patient received immunotherapy in first line. What's your regimen to start for this patient as second line or subsequent line?
Okay, this is a good question. the main thing is the duration. For example, if the patient received 6 months of chemotherapy and immunotherapy, and he maintained response after maintenance of the immunotherapy, for example, pembrolizumab is for 2 years. If he completed 2 years and he became off treatment for 1 year of this immunotherapy, we can re-challenge with immunotherapy if the patient is DMMR. This is the main thing. Single agent can be re-challenged after 1 year of treatment from the immunotherapy, and for dostarlimab, as we know, it is 3 years. If also he remains 1 year off treatment, I can re-challenge with single agent. طيب, this patient is not DMMR, so I will go for pembrolizumab lenvatinib. It's with very good data and very good impressive overall response rate. I will go for pembrolizumab lenvatinib, or if the recurrence came before the 1 year of treatment, I will search for possibility of HER2, for possibility of second line chemotherapy, or NTRK. It is in our pocket also. Tumor mutational burden, if there is a way after 1 year of treatment immuno checkpoint inhibitor, I can use also as per NCCN guidelines.
My question is also, Dr. Hatem, indication for start hormonal therapy. If the patient,
yes,
you have choice to start chemotherapy or hormonal therapy.
Or hormonal therapy. Okay. For all of our endometrial cancer, this is the first line is clearly indicated to start with the new data immuno plus chemotherapy. But in the if the patient has endometrioid cancer and failed first line treatment, the patient cannot afford aggressive second line, we can offer hormonal treatment, especially in ER positive endometrial cancer. Why we are telling like this? Endometrial cancer, as we showed in the data, it is very aggressive. Even in the endometrioid, if it is grade 2 or 3, it is very aggressive, with high recurrence rate, with comprehensive, if it is presented early, stage 1 or 2, surgery, radiotherapy received. Even with this comprehensive treatment, recurrence is there. That's why in the recurrence,
I think,
yes, that's why in the recurrence,
hormonal therapy. I think we can use this hormone therapy in first line if the patient has grade 1 endometrioid ER positive.
In the first line.
Yes. Dr. Ali.
Okay.
If the patient not tolerating chemotherapy,
yes,
يعني fragile patient, you might use it for
first line.
But I will prefer to start with chemotherapy.
Yes. That's why I'm telling it is aggressive even with grade 1 or endometrioid. The patient, if we can save a little bit in the first line chemotherapy and get a good response, I would prefer for chemotherapy.
Dr. Amjad.
Assalamu alaikum.
Alaikum.
Salam rahmatullah.
Thank you very much. Excellent talks by both of my colleagues. Really enjoyed and learned. Thank you very much, Dr. Abdulaziz, for arranging this also. Actually, most of the things are covered. Your question is quite valid, that patients who are MSS, not MSI, what you will do? But according to the NCCN guidelines, they have recommended pembro and dostarlimab in combination with chemotherapy, irrespective of MSS or MSI status.
Yes.
But with the durvalumab, I think you have to be having the tumor MSI high. But pembro and this can be used. But the thing is that the data which Dr. Ali presented, that Ruby trial, dostarlimab, actually this trial has two parts. he presented the data for part 1 only, I think. And
Yeah,
part 1,
part 2 it was including niraparib, and you know,
Yeah.
Yes, as a maintenance.
maintenance. Olaparib
Yes.
with niraparib with
Dostarlimab.
dostarlimab. Yeah.
Dostarlimab.
It's present the part 1 only because it get approval.
yeah, because FDA approval was at that time, I think last year, that it was approved for Dostarlimab with chemo, followed by Dostarlimab in patients with DMMR or proficient both based on this data. Okay, and that also in patients who received maintenance olaparib, it showed significant improvements in patients with MSS stable also. What is your opinion, Dr. Ali, about this?
Yeah, the
Addition of olaparib.
durvalumab, yes, agree with you. The durvalumab.
Not olaparib, niraparib.
No, you mean niraparib with dostarlimab?
Yes, niraparib with dostarlimab. Yes, niraparib.
Yeah, it was. I'm not sure about the results of part B trial. I present only part 1, but about durvalumab with olaparib, the hazard ratio. I guess I presented in the lecture. It was hazard ratio. It was I think 5 or some 0.5 hazard ratio. If I'm not mistaken. Just a minute. I will double check. Yeah, the for those patients with durvalumab and durvalumab with olaparib, the hazard ratio is 0.4. So it is, but the approval of NCCN was for the durvalumab for DMMR. Yes, only.
Yes.
Yes.
Thanks, Dr. Amjad. Dr. Yahya, I have question. Which one from the immunotherapy field included good number of serous types? Dr. Ali.
Yeah, I guess in the I'm not sure about it, but in the Ruby trial, the serous type around about 20%, more broader patient than other either in the durvalumab trial or in the pembrolizumab trial. In the durvalumab trial, did not specify the exact number for the serous cases. Even in the pembrolizumab. However, in the dostarlimab trial, Ruby trial, around 20% they have serous. So I think it's the most broader trial with histological subtype.
Yes.
Dr. Yahya also asked about did they test for HER2 and first line?
The HER2 wasn't in the subgroup and the characters of the trial, but I would examine for the HER2 for the second line. It doesn't change the management. Only if HER2 positive, you might use this in the some sort of some type of breast in the NCC, and they put it for the uterine serous carcinoma or carcinosarcoma for HER2 positive.
Yes.
With the trastuzumab, but I don't know. There is no comparison between the dostarlimab, carbovacli, trastuzumab. If DMMR positive, I will go with the dostarlimab. Definitely, I will not use trastuzumab. I'm not sure about you, Dr. Amjad, Dr. Hatem, Dr. Abdulaziz.
I think in serous patient we can start trastuzumab with the chemotherapy as first line if HER2 positive.
Oh, but
Yes.
this is DMMR. Yeah, but there is the response with DMMR. Dostarlimab was higher. I guess it's not the way to compare between the trial.
Yes.
The response is higher with the dostarlimab.
Yes. The main thing, as I told you, Dr. Abdulaziz, there is some question, there is no answer. There is no head-to-head comparison. For this patient, for HER2, there was no subgroup analysis for the immune checkpoint studies. That's why if you will consider, for example, HER2 positive, and it is the MSI high, I would prefer for immune checkpoint inhibitor. If HER2 positive and MSS, I would prefer anti HER2. For example, yes. For example, also if you used, for example, we used already immune checkpoint inhibitor with chemotherapy, and it is HER2 positive. What is the second line? Trastuzumab with chemotherapy or TDXD? There is no clear answer. There is no clear data about this. You will use your confidence and your mind to gather the data from different studies.
What do you think, Dr. Amjad, Dr. Yahya, Dr. Abdulaziz, in this regard?
My question.
Yeah, I give you my opinion. If it is Demamab, definitely I will go with the Starlimab.
Agree.
Immune therapy.
If MSI high, even if it's positive, I'll go for immune therapy for first.
Yeah, exactly.
Agree, exactly.
I will defer that to the XP for the second line better. Because even if you did not use the immunotherapy in the first line, you use it in second line with the TKI. So better to use it in the first line. There is good data. There is variety of immunotherapy in the first line, and I will defer to the XP for second line. There is good data about it.
Yes. Agree.
But I want a small comment. I want to concur with Dr. Abdulaziz's point of view regarding to hormonotherapy. There is role of hormonotherapy. It is typically used for the patient with advanced uterine cancer with limited performance status, especially with the grade 1 endometrial. You can use tamoxifen as the first line. There is role of hormonotherapy in the first line.
Thank you, Dr. Yahya.
Yeah, just Dr. Amjad, I forget to comment in the result of part B. It was, it was positive trial. It was it met the primary endpoint.
Yes, very right. This is my point. Yes, that's very correct. Yes, I have 2-3 points, small. First of all, I agree with Dr. Hatem about this HER2 positivity. Check for that MSI status and then like that. The number 2, regarding hormonal therapy, I agree with Dr. Abdulaziz, because some patients who have borderline performance status, and endometrial grade 1, you can directly go for hormonal therapy. And I will show you tomorrow one of my patients still admitted, about 7-8 years. Lung metastasis disappeared with hormonal therapy. Tomorrow I will show you the images.
MashaAllah.
Okay. So this is number 2. Number 3.
Hypothesis generated. You cannot apply it all the time.
This is bias, ya Dr. Ali.
This is
expert opinion.
No, it is just an example.
Yes.
I will not change the practice based on one patient. I am not recommending that you change your practice on one patient, but it is example that it sometimes works in a certain circumstance. Because my patient elderly, she was diabetic, she was hypertensive, she refused biopsy, she was in borderline performance status, and we started hormonal therapy. And actually, I preferred estrogen and progestin alternating protocol. There is a protocol.
Yes.
3 weeks on. Maybe Dr. Hatem remembers. He was a part of my team sometimes for this management. Anyhow, the next is that when we check the molecular analysis for endometrial cancer, first test is pol E. And about 5 to 10% are pol E positive. And if you see the graph, even for 10 years, there is no progression.
No recurrence.
So no recurrence. Exactly.
Yes, no
so what is the for such patients? If we did that, and patient fortunately came poly positive. Okay. First of all, what is the explanation, Dr. Ali, in your opinion, that they behave so nicely, so well? And number 2, what will be your approach for such patients? You will still treat same aggressively, or you will just treat a different way?
Yeah, this question has been questioned to the primary investigator of Starlimab, Mirza, and actually those patients who need de-escalation, but right now you cannot do
Yes.
but it further will enhance more trial in this regard.
Yes.
But you cannot stop the chemotherapy. You will finish
The maintenance.
there.
Yes.
Yeah.
Yeah, Dr. Ali, if you remember, if you heard yes.
You will give them chemotherapy. This is the question that has to be asked.
Yeah, exactly. This is the question. You will give them chemotherapy or you will give them only immunotherapy, because these patients actually are hyper mutated. They have maybe 100 to 500 mutations per megabyte. Not we are taking 10 is high,
Yes.
and they are having 100 to 500. Okay, that's why these patients are having very high immune response intrinsically. That's why one explanation is why they are behaving better is that because of very high number of tumor mutations, their intrinsic immune response is significant and they do well clinically. Another explanation is also that if so many mutations are there, patients themselves may not survive because there are so many mutations, they are lethal, some of them.
Yes.
Yeah.
For the cells.
Serious syndrome, because like more.
Exactly. Exactly. So that's why the cells themselves die. But we are not very sure that we should, the patient, we should treat. But I think these patients need further that maybe de-escalation may be needed for such patients rather than treating same, because they have excellent response over years and years.
Yes.
And if you see one graph, I think Dr. Hatem did not elaborate on that. He
Yes.
showed but skipped the slide.
Yes.
But the line was straight for 10 years.
The line was straight, yes.
Yes.
10 years.
السلام عليكم.
دكتور فايز حياك الله، مشرفنا الله.
السلام عليكم ورحمة الله وبركاته.
عليكم
يعطيكم
السلام.
العافية. ما قصرتوا بصراحة.
لا،
مشكورين الزملاء ومشكورين الزملاء في جيسك على صراحة تنظيم الميتنج هذا. صراحة I wanted to make a quick comment regarding hormonal therapy for endometrial cancer. We know like good number of type 1 pathology endometrial cancer, they are, obese, all patients. And some of them, they won't be able to go for surgical resection or surgery because of the comorbidities, and they have also existing comorbidities. And they refer those patients to see radiation oncologists for consideration of palliative radiation treatment or radical external beam and brachytherapy treatment, which is not still considered radical treatment. I have a good experience, honestly, when using MIGAze to treat symptoms for those patients with the palliative intent. And it's not only reducing symptoms and stopping the bleeding completely, they have good response in terms of the endometrial thickening. So I think if we may consider also hormonal therapy for palliative intent, either patients who are not able to go for radical intent treatment or good systemic therapy, and in the palliative intent if they fail the radical treatment in the future. My question to Dr. Rahman, for your patient who had complete response in the lung while on hormonal therapy, which hormonal therapy you used? Dr. Rahman.
Sorry, I was muted. Now sorry. Okay, actually I used a protocol which is tamoxifen 3 weeks on and 3 weeks progesterone. Okay.
Medroxyprogesterone, yes.
Yes. Dose of tamoxifen is not 20, 40 milligrams per day.
Yes.
Okay, 40 milligrams per day, 3 weeks, then 3 weeks, 160 milligram migastrol. Again come back to tamoxifen, alternating, continue till unacceptable toxicity or disease progression. And that's the protocol what I used. And unfortunately now the patient has some toxicity because she developed PE.
Okay.
And now he is almost, yes. And this is, you can find in the literature.
Did you stop the hormonal treatment completely, or
was actually because it is 7-8 years in between, at one time point there was this migastrol was not available, At that time, for a few months, she stopped treatment. Okay, and sometimes also in between 1 or 2 months, the patient stopped at herself. But most of the time during these 7-8 years, she continued treatment till now. But now I will permanently discontinue because she has bilateral PE and she is having no lung metastasis, no lung lesions at least for the timing. And we did scanning again yesterday. We'll get not yesterday, today, and I will see the report. Yes.
The primary is there. The primary is there.
No, primary was removed before, and she recurred in the lungs.
Recurrence in lung.
Yes.
What the duration of use of hormonal, Dr. Abjad?
Yes, sir, sorry.
Duration of hormonal use.
Hormonal use, as I told you, there is no duration recommended for hormonal use. It is depends on the response. And for my patient, 7-8 years.
MashaAllah.
I think, Dr. Rahman, I think you prayed 2 rak'ah before you started the patient.
He is always praying, Dr. Faiz. You don't know him.
This is what he always does, you know, when he has a difficult case, he goes to mosque, prays 2 rak'ah, and come back with his solid decision.
Wallah, confirm.
This is from Allah subhanahu wa ta'ala. No, we are together, and Hatam followed with me this patient. Dr. Hatam may be remembering the patient.
Yes.
يعطيكم العافية. Thank you very much. شكرا يا شباب.
Thank you very much. Thank you very much.
I think there is last question from Dr. Wala. Dr. Wala asked about is there any data about how time is needed to stop durvalumab prior to surgery and second cytoreduction surgery?
Second cytoreduction surgery.
Yeah.
Durvalumab. Nivolumab or durvalumab?
She right, durvalumab.
Durvalumab is not approved in the second line. There is approval for Bembro, Dostarlimab, Avelumab, and Nivolumab.
Yeah. In general, I'm not sure. First of all, I would like to welcome Dr. Wala. She's a gynecologist. We are happy to have a gynecologist serving our patients.
MashaAllah, joined already?
Yeah, she's joined the session. I'm not sure she will join the hospital.
MashaAllah.
I think she started this first week for her. حياك الله دكتورة ولا.
حياك الله.
Dr. First of all, I'm not sure about the role of second cytoreductive surgery. You know, there is some sort of conflict data in the ovarian.
Yes.
I'm not sure about the endometrial.
Yes. But I think Dr. Ali, I think yes.
بنسوي في الاندوميتريال كانسر والادفانس اندوميتريال كانسر. if we start chemotherapy, then patient progressed on chemotherapy or BDL inhibitors. She progressed and it was debulkable mass. We can proceed with cytoreductive surgery or debulking surgery.
Agree.
So my question was, is there any data about when to stop BDL inhibitors prior to the surgery? Do we need the time? Or it's depending on the toxicity and adverse events?
You know, the most toxic medication that we are afraid of is the bevacizumab.
Yes, anti-VEGF is the main thing. Yes.
Huge complication. But regarding the immune therapy, it's not like this. So I would use it like chemotherapy, 4 weeks maximum, and then I would
agree.
It will be but in the bevacizumab, no, at least 2 months, not 6 weeks, 2 months more.
Yes.
Because it will be disastrous for you and for us.
I agree with Dr. Ali.
Totally.
For bevacizumab, more than 6 weeks. For immunotherapy, from 3 to 4 weeks.
Like chemotherapy, like what we are doing.
Yes.
Many thanks, Dr. Shukran, Dr. Ali. Thank you, Dr. Haytham, for a very nice presentation. I'm very thankful.
And one comment for the second debulking, it is always for expert opinion. Whenever there is local available treatment, go for it, even surgery or for radiotherapy.
But if you have recurrence, you have to consult the gynae.
Yes, we will consult Dr. Ali for sure.
Welcome to the club.
Welcome on board.
Thank you so much.
الله يعطيك العافية دكتورة، شرفتينا، الله يحفظك إن شاء الله.
الله يسلمك.
By this I conclude this meeting. Thanks Dr. Ali, Dr. Hatem for this nice presentation. Thanks for GSK team for organizing this meeting. الله يعطيكم العافية جميعا. And thanks for attendance. And I hope see you إن شاء الله in next meeting. الله يعطيكم العافية يا شباب.
شكرا جزاكم الله خير.
الله يعطيكم العافية جميعا. نشوفكم على خير بإذن الله.
الله يحفظك.
شكرا لكم.
السلام عليكم ورحمة الله.
الله يعافيك.